Okay, doctor, so I hope you enjoyed that video on the pain behaviors. Take-home message for pain behaviors is that the presence of pain behaviors and the absence of pain behaviors give you equal amounts of information about the examinee's true condition, and sometimes it's the absence of pain behavior that's more revealing and more compelling than even is the presence of a pain behavior. So, for example, if you have an examinee who's reporting constant and severe pain, you might ask yourself, what's missing here? What's omitted from this scene? And what might be omitted are some of the pain behaviors that you would expect to accompany someone with a bona fide condition, a bona fide painful condition that causes them to have pain that would be constant and severe pain. So be equally observant for the presence and absence of pain behaviors. And many times I find it even more helpful to look for the omissions versus the commissions. As I said earlier in this program, one credible reference that I've listened to extensively and taken home study courses from states that lies are to be found in the omissions rather than in the commissions. Okay? So I hope you got a lot of valuable information out of that discussion. And doctors, I notice now that we are over the 5-hour mark on this program. And so I want to finish up this program and spend the remainder of the time that we have available talking about some physical examination inconsistencies. We just talked about pain behaviors and inconsistencies associated with pain behaviors, but now let's move into the physical exam and spend a little bit of time talking about the famous Waddell signs, the Waddell signs. Now, the Waddell signs were originated with Waddell, MD, and he published an article in Spine magazine, and I believe this was in the early 90s. I don't have that date reference here, but I believe this goes back even as far as the early 1990s. And he published a study entitled Non-Organic Physical Signs in Lower Back Pain. Non-organic meaning that the examinee's pain was not associated with any identifiable organ dysfunction or anatomic dysfunction of the lumbar spine. And so Waddell described several different findings that he considered to be non-organic signs. Nowadays, we refer to non-organic signs also with the term non-physiologic signs. And so you may have heard of the term of non-physiologic signs or non-physiologic examination maneuvers. And basically, what Waddell described are several non-physiologic examination maneuvers that would lead you to suspect that the examinee may be either magnifying their symptoms or possibly even malingering. So let's talk about some of these Waddell signs. And I should preface this discussion by saying that the Waddell signs have been criticized in the years in between the publication of this study and now. And many authorities have discounted and disproven these signs, stating that these signs really indicate nothing. But I think what can be said with certainty is that whether or not any one of these individual signs taking singularly or even collectively, whether or not that indicates malingering is a subject of much debate, but most authorities agree that the presence of at least two of these non-organic signs suggests poor treatment outcomes, suggests that the examinee may be the type of examinee who we cannot expect to have a favorable response to treatment efforts. It may suggest the type of examinee who may show signs of delayed recovery. So at the very least, the Waddell signs suggest perhaps some problems in the response to treatment on the one hand, and at the other end of the spectrum, the Waddell signs may suggest the presence of either symptom magnification and or malingering. But keep in the back of your mind that the Waddell signs have been criticized. Okay? And yet they still persist, so let's talk about them. So Waddell described 8 physical examination findings in 5 different categories of testing. So, for example, one category of testing involved the palpation exam. Okay. Next category of testing involved simulated physical examination maneuvers, or I should call those simulation maneuvers. And simulation maneuvers are maneuvers that appear to be bona fide physical examination maneuvers. However, these physical examination maneuvers should not cause pain in the area of the body being reported by the examinee. The physical examination maneuver is designed to simulate a bona fide provocative maneuver for the examinee's point of pain, when in actuality, the examination maneuver does not even stimulate the point of the examinee's pain. Okay, Waddell described the distractive maneuvers, where we get the examinee distracted and attempt to get them to try to make a maneuver or make a motion that they claimed otherwise that they could not do. We have the non-anatomic or regional findings, and we have the overreactions. So let's talk about each of these one by one. And here's a diagram that sort of simplifies the Waddell signs. Up here you have the Waddell signs in general, and here's the 5 different categories of testing. We have the palpation for tenderness testing, the simulation maneuvers, the distraction maneuvers, the regional maneuvers, and the overreaction maneuvers. Now, the tenderness maneuvers can be broken down into both the superficial palpation exam or the superficial tenderness and the non-anatomic tenderness. A couple of simulation maneuvers that Waddell described are listed here. We have the axial loading maneuver and the truncal rotation maneuver. As far as a distraction maneuver, we're talking here about the lumbar spine. Waddell described the sitting versus the lying straight leg raise testing maneuver. For regional findings, Waddell described widespread weakness and widespread sensory loss, and this is one that I encounter quite frequently, these so-called widespread findings. And then for overreactions, and there are many different types of overreactions, but Waddell described the disproportionate facial expression, a facial expression that is seemingly out of proportion to the provocative maneuver. Okay? So let's talk about each of these individually. Okay, now with the tenderness assessment, we're going to assess for both superficial tenderness and non-anatomic tenderness. Now, superficial tenderness is tenderness to palpation in the level and in the layer of the skin and the connective tissue. So with regards to the lumbar spine, what Waddell did was he performed superficial or light palpation pressure over the lumbar paraspinal muscles and over the lumbar paraspinal fat around the sides of the flanks above the iliac crest. And he considered it to be a non-anatomic or a non-organic sign when the examinee reported a reproduction of lower back pain with palpation of the lumbar paraspinal skin and the paraspinal fat, because there is no anatomic reason as to why palpation of the lumbar paraspinal fat should provoke a mechanical low back pain type of condition, such as a lumbar facet syndrome, such as a disc prolapse, such as a sacroiliac syndrome. And Waddell described the superficial tenderness as a non-organic sign. Also, Waddell described what he referred to as non-anatomic tenderness. Non-anatomic tenderness, that is, palpation in one area that referred pain to another unrelated anatomic area, or I should say another anatomically unrelated area. So, for example, palpation of the spinous processes of the L2 and L3 vertebra should not reasonably refer pain to the contralateral knee and ankle region, as an example. Those two findings would be unrelated anatomically. So Waddell described non-anatomic tenderness as a non-organic sign. Simulation maneuvers, and Waddell described two, and these are commonly employed even today, and I suggest you integrate these into your routine physical examination procedure. One was the axial loading maneuver, and the second was the truncal rotation maneuver. Now, with the axial loading maneuver, again, these are maneuvers that are seeming to provoke lower back pain. Waddell was writing about lower back pain cases back in the day. So the axial loading maneuver is simply performed with the examinee standing, and the examiner places axial pressure down the vertex of the skull to compress the head into the cervical spine, and then secondarily to compress the cervical spine into the thoracic spine, and the thoracic spine into the lumbar spine. And a report of lower back pain with the axial loading maneuver was described as a non-organic sign, because by the time that axial loading went through the vertex of the skull, down into the cervical spine, etc., any load had since long dissipated and diminished and disappeared by the time it approached the lumbar spine. So in actuality, there is no axial load applied to the lumbar spine with this maneuver. So a report of lower back pain with the axial loading maneuver would be considered a non-physiologic or a non-organic sign. Now, similarly, the truncal rotation maneuver is a maneuver where the examinee is standing with their arms to their side, and the examiner approaches the examinee either from the front or the back and grabs the examinee's arms just above the wrists. And the examiner applies axial traction in a caudal direction down the axis of the arms, and simultaneously applies rotation, using the arms as levers, applies rotation to the trunk. Now, if you've ever seen this maneuver performed, or you've ever performed it yourself, you know that the only motion that takes place with truncal rotation takes place through the acetabulum of the pelvis. In other words, the movement takes place at the hip joints. There is no rotation taking place at the lumbar spine. Next, Waddell described what he referred to as the distraction maneuvers, and there are many different types of distraction maneuvers. Waddell described the sitting versus the lying straight leg raise testing, where he began with the examinee seated, and he drew attention to the examinee's knee, for example, by tapping the patellar reflex or doing some type of an examination maneuver around the knee. And while examining the knee, he would extend the knee, and thereby doing a sitting straight leg raise test. Now, in the presence of bona fide radiculopathy, you would expect that this would simulate and reproduce a sciatic nerve stretch test, which would cause the examinee to report pain and would cause the examinee to demonstrate a true objective finding in the form of extending at the trunk, thereby reducing the hip flexion angle and thereby reducing the amount of traction on the lumbar spine nerve roots. And so he would compare that finding with the finding on the supine straight leg raise testing. Now, many examinees are familiar with the supine straight leg raise testing. However, And so those examinees that are familiar with that maneuver, they know that this maneuver is designed to reproduce pain, but they're not as familiar or they're completely unfamiliar with the same maneuver performed sitting. Well, in actuality, they're the same maneuver. And so they should produce the same type or similar finding. And any inconsistency between the sitting versus the lying straight leg raised testing, he considered that to be an inconsistent finding, perhaps suggestive of examinee malingering. And there are many other types of distraction maneuvers, almost really any type of consistency maneuver that you can imagine in your mind can be done in the form of a distraction maneuver. You simply ask the examinee to perform a certain maneuver, and then you go on to several other maneuvers, and then you come around to a same or similar type of maneuver, which in the interim the examinee has become distracted by all the activity, and you simply review these findings for consistency. Waddell also described the regional findings, and he described regional findings as involved either widespread weakness or widespread sensory loss, whereas in a bona fide lesion of the lumbar spine involving one of the lumbar spine nerve roots, in other words, in a bona fide radiculopathy, neurologic findings should be in strictly either a dermatomal or myotomal fashion. So, for example, an examinee with a bona fide L5 radiculopathy, we would expect them to have a very specific and localized sensory loss to the great toe and the dorsum of the foot in the distribution of the L5 nerve root. Well, an examinee who reports widespread sensory loss, for example, numbness of the entirety of the lower leg and the foot, it's an anatomically inconsistent finding. Similarly, with widespread weakness, and again building on the example of an examinee with L5 radiculopathy, we would expect an examinee with bona fide L5 radiculopathy to present with a drop foot, with weakness to ankle, great toe, and all toe dorsiflexion. This examinee might be expected to walk with a drop foot. Well, an examinee who describes not only a drop foot, but also a heel drop, and also weakness of knee extension, and also weakness of hip extension, and I'm making these up, but just giving examples of widespread weakness versus myotomal weakness, could perhaps indicate a non-physiologic or non-organic finding. Finally, Waddell described the overreactions. And overreactions are really just a subset of what we referred to earlier as the pain behaviors. He referred to that as disproportionate facial expressions, where the facial expressions are out of proportion to the provocative stimulus. And this is something that you always want to be aware of. Always looking for pain behaviors that seem to be out of proportion to the physical examination maneuver and the provocation stimulus. Okay? Well, what about some other physical examination maneuvers? What I want to talk to you about now has to do with some other examples of distraction and simulation maneuvers. And I want to share with you a couple of other well-known simulation maneuvers known as the log roll maneuver, the hip wiggle maneuver, and the toe and ankle dorsiflexion / plantarflexion test. Now, all of these are simulation maneuvers that should not produce lower back pain. And let me just describe these to you. With the log roll maneuver, we simply take the examinee, the supine lying examinee, and we take the entirety of the lower extremity in which the examinee is reporting radiculopathy, and we take the entirety of that lower extremity and we internally and externally rotate that lower extremity at the hip. Okay, so picture this: the examinee is lying supine, and I have a live demonstration of this for you in just a minute. We have the supine examinee, and we take the entire lower extremity with one hand above the knee on the quadriceps and one hand below the knee on the front of the tibia bone. And using both hands, we simultaneously, internally and externally rotate that lower extremity, moving the lower extremity only at the knee. This should not provoke lower back pain. This should not provoke radiation of pain into that lower extremity. So an examinee who reports pain in that lower extremity could be perhaps describing a non-physiologic exam finding, because this maneuver should not provoke the pain of radiculopathy. Similarly, with the hip wiggle maneuver, we take the involved lower extremity and we flex the hip 90 degrees. Now, the examinee is familiar with us performing examination maneuvers on the lower extremity. So, for example, we've already by now done some straight leg raising maneuvers. We've done perhaps the Braggart's maneuver. We've perhaps done some 90-90 flexion maneuvers. And the examinee is familiar and comfortable with us manipulating the lower extremity. So this is the perfect time to integrate the hip wiggle maneuver into your routine protocol. So to perform the hip wiggle maneuver, you simply flex the leg at the hip and you flex it to 90 degrees of hip flexion. And then with the knee also flexed to 90 degrees, you simply internally and externally rotate the femur in the hip socket by using the lower leg as your lever. And again, this maneuver should not provoke either lower back pain or lower extremity pain, because there simply is no provocation of the lumbar spine. The entirety of the movement takes place only at the hip socket. Now, the toe, ankle, dorsiflexion, and plantarflexion test also is known as the Gordon-Wellberry ankle-toe test. And the Gordon-Wellberry ankle-toe test is sort of a takeoff on Braggart's maneuver and can be done in sequence immediately following Braggart's maneuver, which is done immediately following the straight leg raise testing maneuver. So the sequence might go as follows. You perform the straight leg raise maneuver and the examinee reports radiation of pain into the lower extremity, and he describes it in a distribution that appears to be consistent with either L5 or S1. Okay, let's use that as our example. Well, let's use L5 as our example. He describes some radiation of pain into the dorsum of the foot and the dorsum of the great toe and the tops of the toes, okay, on the dorsum of the foot in the distribution of L5. Well, that maneuver would be followed up with the Braggart's maneuver, where you lower the leg a few degrees from the point of pain, of the straight leg raise maneuver. You lower the leg a few degrees, and then you dorsiflex at the ankle, thereby reestablishing a stretch on those L5 and S1 nerve roots. This should reproduce pain, and this is known as the Braggart's maneuver. Well, if dorsiflexion at the ankle reproduces pain, then plantarflexion at the ankle should alleviate pain. So first the maneuver is to dorsiflex at the ankle, and then the maneuver is to plantarflex at the ankle, and you make a note of the examinee's findings. Now, to perform the Gordon-Wellberry maneuver, you simply maintain the angle of straight leg raise that you're using for the Braggart's test, and you maintain that angle, but you flex the knee to bring the foot back in contact with the table. Okay, so the hip remains in a position of flexion. The knee becomes newly flexed to drop the foot down to the examining table. From this position, the examiner places the palm of one hand on the distal femur above the knee and takes the other hand and strongly dorsiflexes and plantarflexes, at least to the level of the table. Dorsiflexes and plantarflexes the ankle. Now, this appears to be a maneuver similar to what we just did with Bragger's maneuver. However, with the knee flexed and the foot in contact with the table, this flexion of the knee alleviates the stretch on the sciatic nerve and the L5 and S1 nerve roots. So this should not provoke radiation of pain in the distribution that the examinee described. And in this example, we're talking about the distribution of L5. Okay, so that's the Gordon-Welberry toe and ankle test. So I have a live video here to demonstrate these maneuvers in action. So let's go through these maneuvers one by one, and then come back with you, and we'll talk about some other exam inconsistencies as well. Hi, this is Dr. Perry Carpenter. This video is designed to provide supplemental digital content to the QME Continuing Education Home Study Program, the non-physiologic exam. And in that program, that's a 3-hour continuing education program, we go into extensive detail regarding the non-physiologic exam. And this video demonstrates some of the procedures and some of the non-physiologic examination maneuvers that are discussed in that 3-hour home study program. And I'd like to go over a few of those maneuvers here with you today. I have maneuvers broken down into 3 basic categories, and we're just going to go through quick demonstrations so you get the basic idea of the significance of these maneuvers and how they contribute to your findings and how they contribute to the preparation of your QME reports. So we have these non-physiologic examination maneuvers broken down into 3 basic categories. Number 1 category, the first category, is inconsistent findings. Findings on physical examination maneuvers that would be otherwise inconsistent with subjective descriptions and historic descriptions of both the injury and the examinee's pain. Category number 2 are simulation maneuvers. In other words, physical examination maneuvers that actually should not reproduce pain, but which the examinee reports that there is a reproduction of pain. And I'll go into several simulation maneuvers with you. And then category number 3 are the distraction maneuvers. And I'll explain more about those when we get to those. So to begin, I'd like to go over some of the inconsistent physical examination maneuvers that may be inconsistent with the historic facts of the injury and the treatment history, for example, and also physical exam findings that may be inconsistent with the examinee's reports of pain and the distributions of pain. And some of these inconsistencies will become clearer to you as we go through these maneuvers. So the first one I'd like to share with you is what's called the 90-90 maneuver and its relationship to Miner's sign. So imagine that you are sitting in your interview in the face-to-face evaluation with your injured worker, and you observe your injured worker to be able to sit comfortably in the examination chair. Now, if you make a note of this sitting posture, you'll notice that the hips and the knees are both in roughly 90 degrees of flexion. Correct? And what's the significance of that? There is no significance of that, except if later on in the examination, the examinee demonstrates inability to assume either 90 degrees of hip flexion or 90 degrees of knee flexion. That would be considered an inconsistent examination finding. So during your interview, you're talking and you note that the examinee is sitting comfortably in the 90-90 position. If you then go to physical examination, and perhaps your injured worker is lying on the examination table like so, and you're initiating some examination maneuvers, and for example, you flex the hip and knee, approaching the 90-90 degree relationship, and if the injured worker objects and says, oh no, I can't do that, or they provide resistance to your motion to indicate that they're not going to participate in that movement, that would be considered an inconsistent examination finding. That is what we call the 90-90 finding. Another examination inconsistency that you may encounter involves what's called positive minor sign. Now, with a positive minor sign, due to some sort of limitation, generally it's in the lumbar spine, but it could also be due to pathology in the hip or pathology in the knees. The examinee, in an effort to unweight the injured part, again, whether it be lumbar spine, hips, or knees, will use the chair to assist in the descent. In other words, they use the hands to assist or to alleviate the eccentric phase of the contraction of the spine muscles, of the hip extensors, and of the knee extensors. So they'll use the hands to unweight the eccentric portion, and they'll settle down into the chair like so. Similarly, upon rising from the chair, they will use the hands to assist now in the concentric phase of the contraction. And if you've ever had a pain in your lower back, you know that there's inhibition, there's neural inhibition and weakness of the associated muscles. Okay? So the hands allow a boost out of the chair to relieve those painful and inhibited muscles and allow the injured worker to be able to stand up. So a positive minor sign has two components. It has the eccentric assist and it has the concentric assist. Okay? And you've all observed a positive minor sign. Well, a positive minor sign observed on sitting up and out of a chair, or both into a chair and out of the chair, would be inconsistent with a physical exam finding that demonstrates the ability to perform repetitive squat. Repetitive squat. And a repetitive squat is part of the functional maneuvers generally included with lower extremity exam and lumbar spine exam. But injured workers often, they don't make the connection between the similarity of the maneuvers of getting in and out of a chair and being able to perform a repetitive squat maneuver. So if, for example, your injured worker reports that they're unable to perform a repetitive squat maneuver due to pain in the back or what have you, and yet you're able to observe them to sit down comfortably in the chair, well, those are the same maneuvers. So that would be a physical examination finding of inconsistency. And what does that finding mean? What can you conclude from that finding? Well, actually nothing. Nothing. No one physical examination inconsistency really means anything. You have to take this into the overall context of the case, of the mechanism of injury, of the medical treatment to date, the subjective complaints, and all of that information has to be integrated with your physical exam findings, including findings on non-physiologic exam, in order to come up with a final conclusion that is an accurate representation of the injured worker's permanent impairment or their permanent and stationary condition. Okay, so what did you think of those simulation maneuvers? And I simply show those to you as one way to incorporate those maneuvers into your routine protocol. You can probably think of other ways to integrate those as well, but that gives you some idea as to how to do those maneuvers. And again, these maneuvers should not provoke pain uh, in the presence of a bona fide lumbar spine condition, because these are simulation maneuvers. They should not stimulate the point of lower back pain. Okay, finally, what I want to share with you and make two last points as we wrap up this program. There are many other examination inconsistencies, and you can probably think of many of your own. One of the areas that you want to always keep your eye out for and be in tuned with are the insincerity of effort responses. And remember, we stated that one of the ways that examinees can magnify their symptoms or even malinger is by understating their ability to perform physical examination maneuvers. Another way to phrase that is they give insincere effort on physical examination maneuvers. They say, I can't do that, I can't do that, when actually they can. And you always want to be aware of an examinee when they report to you what they cannot do. You want to make a note as to what type of movement that is and what is the actual physical joint movements and the muscles involved and the nerves involved in the movement that they describe they're unable to perform. If they're truly unable to perform that maneuver by using specific joints, specific muscles, specific nerves, then that should be a repeatable and reproducible finding. If the examinee is later demonstrated to be actually able to perform that specific motion, to use those specific muscles, etc., that would be considered an inconsistency finding due to insincerity of effort. So I want to share with you a couple of these examples. I want to talk to you about the minor sign. I want to talk to you about the Hoover sign. And then I want to talk to you about what we refer to as the 90-90 sign. So I'll share these with you in a live video, and then we'll come back with a couple more comments, and then we'll conclude today's program. Hi, this is Dr. Perry Carpenter. This video is designed to provide supplemental digital content to the QME Continuing Education Home Study Program, the non-physiologic exam. And in that program, that's a 3-hour continuing education program, we go into extensive detail regarding the non-physiologic exam. And this video demonstrates some of the procedures and some of the non-physiologic examination maneuvers that are discussed in that 3-hour home study program. And I'd like to go over a few of those maneuvers here with you today. I have maneuvers broken down into 3 basic categories, and we're just going to go through quick demonstrations so you get the basic idea of the significance of these maneuvers and how they contribute to your findings and how they contribute to the preparation of your QME reports. So we have these non-physiologic examination maneuvers broken down into 3 basic categories. Number 1 category, the first category, is inconsistent findings. Findings on physical examination maneuvers that would be otherwise inconsistent with subjective descriptions and historic descriptions of both the injury and the examinee's pain. Category number 2 are simulation maneuvers. In other words, physical examination maneuvers that actually should not reproduce pain, but which the examinee reports that there is a reproduction of pain. And I'll go into several simulation maneuvers with you. And then category number 3 are the distraction maneuvers. And I'll explain more about those when we get to those. So to begin, I'd like to go over some of the inconsistent physical examination maneuvers that may be inconsistent with the historic facts of the injury and the treatment history, for example, and also physical exam findings that may be inconsistent with the examinee's reports of pain and the distributions of pain. And some of these inconsistencies will become clearer to you as we go through these maneuvers. So the first one I'd like to share with you is what's called the 90-90 maneuver and its relationship to Miner's sign. So imagine that you are sitting in your interview in the face-to-face evaluation with your injured worker, and you observe your injured worker to be able to sit comfortably in the examination chair. Now, if you make a note of this sitting posture, you'll notice that the hips and the knees are both in roughly 90 degrees of flexion. Correct? And what's the significance of that? There is no significance of that, except if later on in the examination, the examinee demonstrates inability to assume either 90 degrees of hip flexion or 90 degrees of knee flexion. That would be considered an inconsistent examination finding. So during your interview, you're talking and you note that the examinee is sitting comfortably in the 90-90 position. If you then go to physical examination, and perhaps your injured worker is lying on the examination table like so, and you're initiating some examination maneuvers, and for example, you flex the hip and knee, approaching the 90-90 degree relationship, and if the injured worker objects and says, oh no, I can't do that, or they provide resistance to your motion to indicate that they're not going to participate in that movement, that would be considered an inconsistent examination finding. That is what we call the 90-90 finding. Another examination inconsistency that you may encounter involves what's called positive minor sign. Now, with a positive minor sign, due to some sort of limitation, generally it's in the lumbar spine, but it could also be due to pathology in the hip or pathology in the knees. The examinee, in an effort to unweight the injured part, again, whether it be lumbar spine, hips, or knees, will use the chair to assist in the descent. In other words, they use the hands to assist or to alleviate the eccentric phase of the contraction of the spine muscles, of the hip extensors, and of the knee extensors. So they'll use the hands to unweight the eccentric portion, and they'll settle down into the chair like so. Similarly, upon rising from the chair, they will use the hands to assist now in the concentric phase of the contraction. And if you've ever had a pain in your lower back, you know that there's inhibition, there's neural inhibition and weakness of the associated muscles. Okay? So the hands allow a boost out of the chair to relieve those painful and inhibited muscles and allow the injured worker to be able to stand up. So a positive minor sign has two components. It has the eccentric assist and it has the concentric assist. Okay? And you've all observed a positive minor sign. Well, a positive minor sign observed on sitting up and out of a chair, or both into a chair and out of the chair, would be inconsistent with a physical exam finding that demonstrates the ability to perform repetitive squat. Repetitive squat. And a repetitive squat is part of the functional maneuvers generally included with lower extremity exam and lumbar spine exam. But injured workers often, they don't make the connection between the similarity of the maneuvers of getting in and out of a chair and being able to perform a repetitive squat maneuver. So if, for example, your injured worker reports that they're unable to perform a repetitive squat maneuver due to pain in the back or what have you, and yet you're able to observe them to sit down comfortably in the chair, well, those are the same maneuvers. So that would be a physical examination finding of inconsistency. And what does that finding mean? What can you conclude from that finding? Well, actually nothing. Nothing. No one physical examination inconsistency really means anything. You have to take this into the overall context of the case, of the mechanism of injury, of the medical treatment to date, the subjective complaints, and all of that information has to be integrated with your physical exam findings, including findings on non-physiologic exam, in order to come up with a final conclusion that is an accurate representation of the injured worker's permanent impairment or their permanent and stationary condition. Okay, doctors, did you get some new insights out of those simulation and inconsistency maneuvers? As I said earlier, there are dozens and dozens of different types of inconsistency observations, and you probably have your own that you rely on, and there's no shortage of them, and there's no real limits to the types of inconsistency maneuvers that you can employ. And that brings us to the final point that I want to make in today's program. And I want to talk to you just briefly here today about objective tests. Now, it's interesting, in the AMA guides in the spine chapter, chapter 15 on page 375, there's a fascinating and illustrative quote on page 375, and it basically says, and this is not word for word because I'm coming out of my memory on this, But it basically says on page 375 that many physical findings are subjective, meaning that they are under the control of the examinee. They're subjective. Physical findings are subjective. Now, what does that mean? That means that when we perform what we consider to be an objective test on the examinee, such as the straight leg raise test, we consider the straight leg raise test to be an objective test. So, but the AMA guides counsel us by saying that many physical findings are subjective, even though we use objective tests. Now, the AMA guides go on to say that we as the examiner should appreciate this. We should appreciate that many physical findings are subjective. However, they say that we should not confuse these findings with truly objective findings. So in other words, a subjective complaint on an objective test is not what the AMA guides consider to be a truly objective finding. And the AMA guides use that exact phrase. They say a truly objective finding. So that brings up an interesting idea and an interesting topic, and we could talk about this at great length. But I just want to leave you with this today, and that is that subjective complaints on objective tests do not constitute a true objective finding. We really have only 3 types of truly objective findings upon which we can rely in our physical examination. And I'll talk about the first 2 of these very quickly and spend some more time talking about the third. The first one is measurements for atrophy. Atrophy, of course, is not in any way reliant upon the response of the examinee. So a measurement of atrophy is a true objective finding. Gait also provides us some measure of a true objective finding as well, especially in the presence of normal gait. When we have an examinee who has completely normal gait, that tells us a lot about the function of the sensory system, tells us a lot about the function of the motor system, tells us a lot about the function of the neuromusculoskeletal system in general and in specific. Normal gait is suggestive and indicative of normal function of all of those structures. So gait qualifies also as one of our truly objective tests. And then finally, reflexes are also one of our very few truly objective tests. Now, I love reflex testing. I love reflex testing. The reason I love reflex testing is because reflexes are completely objective. An examinee cannot influence the outcome of reflex testing. So when we have an examinee who has normal reflexes, for example, and we're talking here about lumbar spine radiculopathy cases to follow up with Waddell's work, when we have an examinee who has normal patellar reflexes, they have normal medial hamstring reflexes, they have normal Achilles reflexes. When we have normal reflexes, despite all the subjective complaints that the examinee reports to us, despite all of those, whatever they may be, the pain, I can't do this, my life is ruined, my kids hate me, I can't bend, lift, stoop, squat, the pain, the burning, the numbness, the tingling, the lancinating, the burning, the electrical pain, the lightning pain, the shooting pain, the stabbing pain, regardless of all the subjectivity that the examinee tells us, when we have normal reflexes, that tells us that a lot of structures are functioning properly. You have to have a lot of structures functioning normally to provide normal deep tendon reflexes. Similarly, with pathologic reflexes, that's a truly objective finding. That tells you that there are structures in the spinal cord that are not functioning properly. But what I want to talk to you before we conclude today's program has to do with a different type of reflexes, known as the withdrawal reflexes. The withdrawal reflexes. Now, the concept that I want to leave you with here today, and this is going to be one of the most powerful concepts upon which you can rely for the entirety of your career. When you're making decisions about your examinee's true condition, you can rely on the reflexes, and specifically, you can rely on the presence or absence of withdrawal reflexes to give you some indication as to the examinee's true condition. And the concept that I want to leave you with has to do with pain and a person's normal response to pain. Now, the American Academy of Pain Management defines pain, and they go on to say that pain is an unpleasant sensory and emotional experience. It's caused by a noxious stimulus. It causes physical discomfort such as prickling, burning, stabbing, numbness. And this is not an exact definition. I'm coming off my memory with this. But it's very close to what I'm saying here. And then the final description in the definition of pain is they say that pain leads typically to evasive action. So let's repeat that. It's an unpleasant sensory and emotional experience. It's caused by a noxious stimulus received by naked nerve endings and causing physical discomfort such as prickling, burning, stabbing, shooting pain, etc., and typically leading to evasive action. Pain leads to evasive action. Now, our physical examination maneuvers that we employ in our routine physical exam are designed to reproduce pain. Our physical examination maneuvers that we use are designed to stimulate the painful body part. True objective findings are involved, or I should say, true objective findings involve some form of evasive action. It's a form of the withdrawal reflex. And I want to take you all the way back to your neurophysiology training, way back, probably in your graduate or maybe even in your undergraduate training, where you learned about the flexor withdrawal reflex. And if you remember the flexor withdrawal reflex, typically they demonstrate the flexor withdrawal reflex by showing a person touching their finger to a hot stove, or perhaps by demonstrating a person stepping on a sharp tack. And in both of those circumstances, there's an instantaneous, immediate, and reflexive, and that's the key word, is that it's reflexive. There's a reflexive withdrawal from the painful stimulus. So in the case of the hot stove, the biceps brachii muscles are immediately activated reflexively to flex the forearm and withdraw the finger from the hot stove. It's reflexive. It's not cognitive. It's a reflex. It's a form of evasive action to get away from the pain. And true objective findings in our physical exam should include some form of evasive action. And I'll just give you a couple of examples as we bring this program to a close. For example, in the presence of a bona fide L5 radiculopathy, when you perform the straight leg raise maneuver and the hot L5 nerve root comes under tension, that is going to reproduce pain along the distribution of that L5 nerve. Now, in the presence of a bona fide L5 radiculopathy, a true objective finding would be some sort of a maneuver by the examinee to evade the pain. How could the examinee evade the pain? Well, one thing they could do to evade the pain would be to extend at the hip, thereby reducing the hip flexion angle. What else could they do? They could also flex at the knee, thereby decreasing the traction on that hot nerve root. What else could they do? They could also plantar flex at the ankle, which would also reduce the traction on that L5 nerve root. These are three examples of 3 different forms of withdrawal reflex that would serve to evade the pain associated with the straight leg raise maneuver. What's another form of flexor withdrawal reflex? Have you ever heard of the shoulder apprehension test? The shoulder apprehension test. The shoulder apprehension test is performed to assess for shoulder instability. If you have an examinee who suffered a prior shoulder subluxation or a shoulder dislocation, they will be left with some degree of shoulder instability. And when you go through the shoulder apprehension maneuver, if the examinee senses, or if they feel, or if they fear, and this is not cognitive, by the way, this is reflexive, but if they sense a pending subluxation or dislocation of the head of the humerus from the glenoid fossa of the scapula, they will reflexively, they will provide what's known as the apprehension sign. What is the apprehension sign? The apprehension sign is some movement, some wiggle, some maneuver, some wriggle, some repositioning, some shifting of their body, of their arm or their torso, the purpose of which is to reestablish congruity between the joint surfaces of the head of the humerus and the glenoid fossa of the scapula. It's reflexive. It's a form of evasive action. It's actually an example of the withdrawal reflex. Though the principle that I want to leave you with here today is that true objective findings are accompanied by some form of evasive action. Evasive action is a manifestation of the withdrawal reflex. So always be on the lookout for the presence of the withdrawal reflex, for the presence of an evasive action. And as we talked about earlier, both the presence of a withdrawal reflex and the absence of a withdrawal reflex tells you something. And many times it's the absence or the omission of the withdrawal reflex that's more telling even than its presence. So, for example, what does an absent flexion at the knee in the presence of a hot L5 nerve root that's provoked by the straight leg raise test, what does that tell you? That tells you that it's not that hot, right? It's like touching your finger to a stove. You can keep your finger on the stove pretty long if it's not too hot. It's when the stove gets hot that your finger withdraws from the stove. The response of your finger withdrawing from the stove gives you great information about the temperature of the stove. And so the absence of a flexor withdrawal reflex on the straight leg raise testing gives you a great deal of information about the severity of any L5 radiculopathy in this example that we're talking about. So always be on the lookout for the presence or the absence of the flexor withdrawal reflex.